Good morning and welcome to Complex Concepts of Adult Health. I'm Dr. Schlegel and we're going to start right at the beginning with Chapter 3, Health History and Physical Examination. Possibly the most important thing we'll do for our patient, an assessment. We're going to start with that patient's health history. What problems have they had in the past? What problems do they have running their families? And that's going to give us a good guide to go on for things that they may be at risk for. From there, we're going to move on to that physical examination, where we're going to start with that thorough head-to-toe assessment. We're going to assess every aspect of this patient to both assess problems that they're aware of and possibly even identify problems that they're unaware of. We're going to use this to identify the patient's current and past health status. This is not only going to help us focus on their chief complaint, their current problem, but this is also going to clue us into problems and issues that they may be at risk for. And this will all provide that baseline for further evaluation as we then move on to a focused assessment. The purpose of that assessment is data collection. And there's going to be many different forms of data that we're going to collect. The first is that medical focus and that medical history. It's used by the provider to determine the risk for disease, diagnose those medical conditions. A medical history is usually collected by a member of the healthcare team, whether it's the nurse, the physician, the NP, or any member of the healthcare team actively treating that patient. The provider's physical examination and diagnostic tests aid in establishing medical diagnoses and implementing and monitoring the medical treatment plan. The information collected is used by the healthcare team members, even the pharmacists, physical therapists, dietitians, social workers, based on the focus of their care and the nature of their chief complaint. What is our active problem that we're setting out to treat? This is not to be confused with the nursing focus. That nursing care is the diagnosis and treatment of that patient's actual response to that treatment, the potential health problems, and treating that patient as a whole you're going to see is a major focus throughout those nursing diagnoses. During the nursing history, interview and physical examination. You'll obtain and record the necessary data to support the decisions about that nursing care. And within that, you're going to have two different types of data. And you'll see this come up a lot. You may have already seen this in your fundamentals course. The first is going to be that difference between subjective and objective data. Subjective data is what that patient reports, and versus objective data are signs, symptoms, and information that we can physically see, measure, and gather ourselves. A great example of that would be a headache. If a patient comes in and reports a headache, that is subjective data. You as the nurse, we cannot see that headache. We can't measure that headache. We may be able to see that the patient's in discomfort, which would be an objective sign. But generally speaking, we can't see, measure that headache. We have to take the patient's report of that. On the other hand, objective data would be we take a patient's blood pressure, get a blood pressure reading of 210 over 140. We now not only have objective data, we also have an objective reason of why they have that subjective report of a headache. And the purpose of that patient interview is to obtain that health history. Open that lines of communication, because that effective communication can be used throughout the interview process. Create a therapeutic climate, get that therapeutic rapport going that we've talked a lot in our mental health class. Also to open an open, responsive, and non-judgmental approach. You want your patient at ease. You want your patient to trust you. You want your patient to open up and tell you of what's going on. And those symptoms experienced by the patient are not necessarily observed, so we need to ask further questions. We need to ask that patient what led up to this. What was the onset of these issues? Is there anything that makes the problem better or worse? Can they describe it in their own words? And it's best to obtain that information in an organized and systematic way to make sure that nothing's missed and we've thoroughly assessed that patient. Culturally competent care. This is going to be an area we're going to talk about a lot in our mental health course as well. And keep in mind, each patient is going to be unique. Each patient will have their own unique requirements and will respond in their own individual way. But also being aware of different cultural norms can also help you as the nurse to provide more effective treatment. Knowing the cultural norms, asking about their cultural values. Some cultures will be very open and talk to you about their problems. They'll tell you they're in pain. They'll tell you what's going on. Other cultures will be very closed off, much more reluctant to tell you what's going on. They may minimize their pain. They may be Some will be much more comfortable working with you than others are. And being aware of this, during the interview and the physical examination, be sensitive to issues. Some cultures are very comfortable with eye contact. Other cultures avoid eye contact. And it's not necessarily anything you're doing. It's understanding those differences. I used to work for the Cleveland Clinic in organ transplant, and it was one of the few places in the world that would do intestinal transplant. So I would have patients coming from all over the world for these intestinal transplants, and you would see drastic differences in the way they respond to treatment, having different requirements. If it was a female from the Middle East, me as a male nurse, I'm automatically going to be out, usually speaking. They would much, much, much more comfortable having a female nurse, and that's understandable. Making sure that that patient is as comfortable as possible is going to go a long way in helping us provide effective care. The subjective data. Starting with that health history. That health history provides the information about the patient's prior state of health, including major childhood illnesses, adult illnesses, previous injuries, previous hospitalizations, surgeries, and all of this could clue us in both on the current problem as well as problems that patient could be at risk for. Because not only is that something we need to be aware of as nurses, that's going to be a big thing that NCLEX is going to test you on as well. Is, are you able to look at a current patient situation and identify the risks and dangers they could be in down the road? Also, medications. Ask for specific details related to past and current medications. What were you taking? How much? Why? How long? Do they understand what they were taking? Has it been multiple providers writing different prescriptions, or have they been on one specific provider? Also, don't forget about illegal drugs, over-the-counter drug use, vitamins, supplements. All of these can play a major role in the patient's state of health as well. Allergies, that's a major, major one to be aware of. There's a lot more allergies out there than you would think. And it seems to be that there's even more, people are allergic to a lot more than they used to be. Peanut allergies are a big one. It used to be eating a peanut butter and jelly sandwich was almost a cliche for a kid. Now there's so many peanut allergies out there, I'm not even sure if you could bring a peanut butter and jelly sandwich into most elementary schools. Think about alternative therapies. Think about chronic illness and the effect that chronic illness could have had on that patient's long-term state of health. The difference between an acute versus a chronic illness. Because as those chronic illnesses wear on, they can become much, much more difficult for the patient to deal with, even leading to psychiatric issues such as depression. And also those surgeries. Make sure you're really asking about those surgeries. Have they continued to have issues? How did they recover from that surgery? Other aspects of that subjective data are their functional health patterns. First being the patient's perception of that injury, patient's perception of their own health problem. You'll find wild differences in the way that patients perceive and manage their health issues. What may be a debilitating issue for one patient may be a minor inconvenience for another, when on the surface, that may seem like the exact same injury to you as the provider. How that patient manages that could be drastically different from patient to patient. Other things such as nutritional and metabolic patterns. How is their nutrition? Are they eating at home? Are they eating right at home? How are their bowels? Don't be shy. Don't be afraid to ask their patient about their bowels. You're going to get away from that shyness and reluctance to ask personal questions really quickly as you get out there working. Their elimination patterns, their activity and exercise. Some patients are very active, and other patients have a very sedentary lifestyle. And for a lot of people, you really can't judge that based on just a physical glance. Obesity isn't necessarily the indication of how active that patient is, of whether they're working out, whether they're exercising. Also, sleep. Sleep and rest is a serious issue within this country. There are a lot of people with very, very, very poor sleep hygiene. I was one of them for a long time. I was a night nurse working night shift for the majority of my career. And it took me many, many years to really get used to that morning day shift pattern. Even when I go on vacations, as soon as I'm off vacation, I think I just naturally go to that night schedule. And it will take me a week just to get back onto used to waking up at 7 a.m. waking up and effectively going to work at 7 a.m. without a lot of coffee. And everyone's different. Some patients in the hospital will stay up all night watching TV, and others, they want their evening medications as early as possible so they can zonk as soon as the sun's down. And doing everything we can to provide that care. Another aspect to be thinking about is trying to group our treatments together so we can give that patient as much uninterrupted rest as we can. You think about, too, especially when you're on your clinical sites, when you're on your clinical rotations, of just how often that patient is disturbed. We have to do our jobs. We have to provide our interventions, our assessments, our vitals. But is there ways that we can provide that while giving the patient uninterrupted rest? And the benefits that uninterrupted rest could provide for that patient's a big thing to think about as the nurse. Even working in med-surg or one of those medical specialties, don't discount the role of the psychosocial aspects, and don't be afraid to assess that as well. What is that patient's self-perception? What is that patient's attitude about their self, their perception of their own abilities? Do they feel confident that they could care for themselves? Are they going to be able to provide interventions and self-care for themselves once they're discharged? Or are they going to go back to the same unhealthy environment that possibly led them to be there in the first place? Also, think about their support systems. Assess their support systems. Do they live alone, and are they able to care for themselves? Do they have family living with them? Do they have family that they're in contact with? They may have a large family, but it doesn't necessarily mean they're close or in any close contact. Other their coping abilities, their ability to deal with stress, their values, their beliefs. All of this can play a major role in both the treatment of that patient and also how effective they're going to be at preventing a recurrence. Moving on to objective data, we'll start with that general survey, that head-to-toe assessment, that thorough assessment of that patient. And this is going to form our general impression of that patient. We're going to include everything from body features, their mental state, are they alert and oriented? Their speech, are they clear, coherent, does it make sense, are they responding appropriately? Their body movements, obvious physical signs, their nutritional status, and behaviors. And all of these aspects together would combine to form our larger picture of our patient. Again, that physical examination is that systematic assessment of the patient's status. We want to look at both our positive and negative findings. Positive would be a finding that's there that shouldn't be, versus a negative finding would be something that isn't there that should be. Think of things like apathy. That patient could be very withdrawn, and that would be considered a negative sign or symptom. And we're going to use a lot of different techniques to do this general survey. Everything from inspection, visually looking at the patient, auscultation, listening to the patient's lung sounds, listening to the patient's bowel sounds, to palpation and percussion. Palpation, we're going to feel it. Does that abdomen feel rigid? Are we hearing increased tympany, increased echoes with light percussion? And again, using a wide variety of techniques is going to go a long way in helping us accurately assess this patient. Walking in, using inspection, using auscultation. These are very common. Everyone's aware of these techniques, but don't discount the benefits of palpation as well. Using light and deep palpation, you can use information such as masses. Are we having pulsations such as an aneurysm within the abdomen? Organ enlargement, tenderness or pain, swelling, muscle spasms, rigidity, elasticity of the skin, vibrations to voice sounds, crepitus, moisture, texture. This is a physical technique that is underused, but should be much more encouraged. We've talked about inspection and palpation. Now let's talk about percussion and auscultation. The use of sound in assessment. And especially for auscultation, this is going to be a very important piece of assessment. It always kills me when I see people come out of doing their patient assessment and they don't have their stethoscope. You've charted, you've done your breath sounds. It really is a key piece of equipment. Finding a comfortable way to carry that. You don't have to have that cutting edge, most expensive stethoscope. I use a cheap Littman I got offline. Just right fits right in my pocket. And it's important, being able to identify any fluid in those lungs early, identify any adventitious breath sounds early, making sure you're assessing those bowel sounds. That can take a little bit, but it's really key that we assess those bowel sounds and find any obstruction or blockage early. Probably our least used assessment technique is going to be percussion. Percussion is the sound and vibrations used to determine the underlying structures within the body. Obviously, nowadays we have MRI, X-ray, but you think back before that, how could a practitioner determine those underlying structures? And the widely used technique was going to be percussion. And as you can see in our diagram, he's putting his finger there and striking that finger to send vibrations through the body. And a change in the expected sound may indicate everything from fluid, air, or unexpected solid masses underneath the surface. And the chest can be used to identify fluid, to identify leaked air, identify enlargement of the liver, enlargement of the spleen. And in this way, a skilled practitioner could have a good idea of what is under the surface that may not be able to be assessed or heard in any other way. Other aspects of that physical examination, we've already touched on the importance of having a logical sequence, keeping it organized. We start at the top of that head and work our way down. And that way we can ensure nothing's missed. You're going to have a lot of things to assess, and there's not really a mnemonic for that. Starting at the very top and working your way down, making it routine, making it a habit. We also want to make sure we're ensuring the patient's comfort, safety, privacy, making sure your patient's comfortable, making sure we've done everything to keep the room temperature at a comfortable temperature for the patient. For safety, you want to ensure both the patient's safety as well as yours. If you're assessing the patient in a bed, make sure the rail on the opposite side of the bed is up while the one that you're working on down. You also want to make sure that the bed is at a safe, comfortable height for you as well. Back injuries are very, very common in nursing, and you really want to do everything you can to protect yourself as well as the patient. And finally, ensuring privacy. You're going to be exposing a lot of private areas of the patient. You're also going to be talking about sensitive topics for the patient. We want to make sure that door's shut. We make sure we've got the curtain drawn if possible, and we want to do everything we can to ensure privacy and make that patient as comfortable as possible. Other types of assessment. A big one's going to be emergency assessment. This is, just as it sounds, done in an emergency or life-threatening situation. It involves a rapid history and exam of the patient. We're going to be prioritizing those ABCs, airway, breathing, circulation, find out exactly what is causing this emergency situation. Others, such as the comprehensive assessment, include that detailed health history and physical exam of all body systems. And that focused assessment, following our comprehensive assessment, we've assessed every aspect of this patient. We're now focusing in on the patient's problems. And it's an abbreviated health history and exam, used to evaluate the status of a previously identified problem, monitor for signs and symptoms of new problems, any changes in this issue. And what we've touched on is only brief examples of the many different types of assessment you'll see out there. And each of these assessments are going to be very specific for the type of setting you're practicing in. The setting within an inpatient is going to be much different than that of an outpatient setting. For an acute care setting, it's going to be different because this patient is very frequently monitored. Do we need to do a head-to-toe assessment every hour on this patient? Every single person that walks in the room need to do a head-to-toe assessment every single time on this patient? Focused assessments of the hospitalized patient are frequent, and they're performed by many different practitioners. And once this patient is admitted, as we've worked with this patient, we can move to that more frequent focused assessment. Once you have that first assessment on a patient during rounds, continue to gather that information throughout your shift. We want to get that thorough initial assessment, and then we really want to make sure we're accurately charting and documenting any patient changes. When obtaining an initial health history from a patient who immigrated to the United States several years ago, it's most important for the nurse to do this first. A. Ask permission to touch the patient. B. Explain to the patient the values and beliefs of their own culture. C. Determine the extent of the patient's identification with their cultural group. Or D, engage the patient in general, non-threatening conversation before asking direct questions. And just breaking it down, which would be the most important is going to be A, asking the patient's permission to be examined, making sure the patient is comfortable, making sure the patient is aware they're going to be touched and examined. B and C are obviously out. And D, well, yeah, that can definitely be an important intervention, making general conversation, building a rapport with the patient when you walk in. Don't just walk in and go straight to it. But definitely the answer is going to be A here, as what is the most important for the nurse to do first is going to be to get that patient's permission, make sure they're aware they're about to be examined. Whereas your textbook's answer to that previous question is C. Determine the extent of the patient's identification with a cultural group. I'm going to leave that in there. I am not going to change that previous slide. I'm not going to change that previous slide. I still believe that answer is going to be A. What is it most important for you to do first? And that is make sure that your patient knows they are going to be examined. Make sure your patient knows that they're going to be touched. Answer C, determine the extent of the patient's identification with cultural group. That's an important thing to do. We want to make sure we're culturally compliant. We're making that patient as comfortable as possible. Everything from eye contact, space, modesty, touching, and violating any culturally based practices. Yes, that is going to be important. But is that going to be the very first thing we do is make a cultural judgment of the patient? No. We're going to walk in. We're going to get their permission to be examined. We're going to build up a small rapport, and then from there we can do a deeper assessment about what that patient would require. Yeah, I'm not changing it. And our last question. The nurse takes a health history and performs a physical examination on a patient admitted to the hospital. The nurse would be most concerned if what occurs? A, the patient reports intermittent abdominal pain. B, the patient requests the presence of a family member. C, the patient suddenly develops severe shortness of breath. Or D, the patient is unable to provide a list of current medications. And I'm sure many of you are screaming it right now. That answer is C. The patient develops severe shortness of breath. Sounds like we're developing a PE or some sort of respiratory emergency going on. And that's always going to be your top priority when it comes to airway and breathing. C, the patient develops severe shortness of breath. And I know we touched on this earlier. A lot of, especially students in lower levels of nursing programs, will always talk about there's multiple correct answers for a nursing question. And as you advance throughout the program, you're going to see there is only one. There is one most correct answer. And there's a lot of different ways to write an NCLEX test, but at the same time, they have very hard parameters these are written by as well. And that ABCs, that is non-negotiable. Airway, breathing, circulation. Those are the three things that could kill the patient the quickest. And you're going to see this type of NCLEX question come up a lot. You're a nurse coming on shift and you have these 4 patients, which should be seen first. It is the one with the airway problem. It is the one with the breathing problem. It is the one with the trouble breathing, because that is what would kill the patient the quickest. And then from there, we'll look at blood pressure, circulation, and then just move down our line on our Maslow's chart. And finally, finishing up this chapter, I've included a video with a head-to-toe assessment. And that'll be the next video down in your Blackboard file under Chapter 3. It plays a little better if you just open it up in its own separate link as opposed to embedded within this PowerPoint. And again, if you have any questions on anything we covered today, feel free to reach out anytime. Shoot me an email, shoot me a text, and I'll get back to you quick. I'm also happy to jump on any Zoom or WebEx call or anything if you need any further discussion or any further help with any of this. Otherwise, good luck, and I'll see you in the next chapter.